Excellent. The reason I wanted to check that is because I'm just going to I've only used a single reference for all of the images and things used in this presentation. I just want to make sure that I'm crediting Cunningham's textbook of veterinary physiology for all of them on camera to make sure that it's done. So the cardiovascular physiology chapters, there was heaps of them, and I found the vascular ones were a lot of kind of common sense and stuff that we're going to discuss when we get to hypertension and things like that. The main thing clinically that I sort of want to teach Josh, and therefore all of you have to come along for the ride, is kind of, I guess, the nitty-gritty electrical movement of ions and things into and out of the cardiac cells, why cardiac cells are different from other muscle cells in the body, and how that then is clinically applicable. So, for example, what happens when our heart failure patient has a low potassium level and stuff. So with this physiology, this is going to be very kind of electrical base kind of physiology stuff. And then in a couple of weeks, we'll do the neurohormonal mechanisms of heart failure. So actually bring some pathology into it. I'll try and make it as clinically relevant as possible, and feel free to obviously always jump in as we go. Okay, a couple of definitions, and I'm not going to go too much into the vascular stuff, but this is the first chapter, so this is where we start. The main thing that we'll sort of be talking about is the sort of gradients across vessels, but also across cells. So I think this is a relevant image. So to make sure that all the cells in the body are getting blood flow, the blood has to be able to get there. So the pressure inside the vessel has to be higher than the pressure outside the vessel, because otherwise the pressure outside the vessel just squashes it down and the blood can't get through. So that's called the transmural pressure, but also called a pressure gradient. So we'll use both of those terms as we're discussing cardiovascular physiology and everything else physiology. And then also we need the pressure at the sort of top end of the vessel to exceed the pressure at the bottom end of the vessel. Otherwise the flow is reversed, obviously. So it's just going to go in the direction. So that's called the perfusion pressure. The other gradients that we talk about will be the electrical gradient and concentration gradient, as well as the pressure gradient throughout today. And that refers to cells rather than vessels, and the movement of ions in particular with the concentration gradient. You guys probably saw all of this with your study, but essentially the point of this very detailed diagram is that the right side of the heart works in series with the left side of the heart. So blood comes out of the right side of the heart, goes up to the lungs, comes back down to the left side of the heart, and then goes out to systemic circulation. So when we talk about pulmonary circulation, it's kind of one unit on its own. Whereas the left side of the heart is pumping to the whole rest of the body. So there has to be mechanisms in the whole rest of the body to prioritize blood flow to certain areas, depending on what activity levels and things that, sympathetic activity, parasympathetic activity, digestion, all of those things, activity, shunting blood to the muscles, all of those, obviously very important. I think it's also, talking about cardiac physiology specifically, important to sort of discuss the blood flow peripherally, because it helps me to sort of get a visual of what the heart's trying to achieve. So in a large artery, we've got really fast flow in centimeters per second. And then as it branches into smaller components, we get an increase in surface area, which means that everything can just run a little bit more slowly. And again, there are a couple of new people here today. I'm a really visual learner. I don't like using words at all. And I really like concepts. So I really, visualizing this, I'm sort of thinking of like a big river running into some really slow flowing tiny little creeks and tributaries and things. So just get a little visual that really sits nicely with you to picture how the heart, kind of what it's working against, and then how the pressure changes as it goes through the vascular system. So obviously blood flows from the heart into the aorta and then gets shunted into the areas where it's sent according to vasoconstriction and what's going on, into smaller arteries, into arterioles that then feed into these capillaries. Now, capillaries are really tiny. They're really slow flowing. And essentially every single cell in our body, almost, that's not correct, sorry. Every cell, most of the cells in our body are in contact with a capillary because nutrients need to get to every single cell. But diffusion, so if you're like 3 cells away from that blood supply, you're going to get a lot less nutrients than the cells right next to it. And you'd end up with kind of regional ischemia. And that doesn't work because the cells will die off and have a different rate of regeneration and things. Whereas in the sort of structure of the body, with everything having its own blood supply, it means that all the cells have similar life expectancies and things, obviously within each organ. All right. So actually going back to that, what is the pressure in the arterial system? So we've talked about flow is high. What about pressure?
I'm thinking it's about 15 millimeters of mercury.
In the aorta, for example, in the large artery?
No, that's much higher.
Yeah, good, excellent.
What you meant, sort of capillary pressure, sorry.
No, it's actually a really good point. So we'll work our way from the arteries through to capillaries through to veins as far as pressure goes. So high pressure system. So what millimeters of mercury would you expect in the aorta?
120 or like systolic blood pressure.
Good, exactly. So it's variable, isn't it, according to the heart pumping. So when there's during systole, it's the systolic blood pressure, so 120-ish, depending on the animal. And then during diastole, the aortic valves closed, the pressure in the aorta or the large vessels drops down to around about 80. So diastolic pressure. So just making sure that everybody's got the link between obviously blood pressure and that being the pressure within the large arteries. And then when we get down to these increased surface areas, there's a lot lower pressure because these vessels are really leaky. So if you had a high pressure flow, all of the fluid would just ooze straight out into the interstitium. So it has to be really low pressure. And then when we go into the veins, does anybody know what millimeters mercury pressure in the venous system, the large veins? Central venous pressure?
Quite low, isn't it? I'm just trying to think like right atrium's around like 4.
Perfect. Yeah, exactly. So 3 to 5-ish is normal venous pressure. So if you think about, we've got the same amount of blood coming out of the left side of the heart as we've got returning to the right side of the heart. So all of that blood's coming back. And we've got a really, really high pressure coming out of the left side and really, really low pressure coming back in the right side. So that means that the venous system contains way more blood because it's so much lower pressure. So the venous system is much more extensive than the arterial system. So arterial system at any given time will contain about 20% of the blood in the body. The venous system will essentially contain the rest, apart from what's actually in the heart at that time, or the capillary beds. I think that's all. Oopsie, sorry. Okay, so now talking about how the heart itself and kind of, I guess, a little bit of muscle structure and physiology. Does everyone remember this from vet school? Yep. So any muscle that can, well, the skeletal muscles and cardiac muscles are quite similar in their structure or the way that they generate contraction. And I'm not going to go into too much detail, but the most important thing about the cardiac muscles is that they kind of work together. So an action potential generated in one heart muscle, so this one, for example, will pass that action potential into the adjacent heart muscle through gap junctions in these intercalated discs. So heart muscle is different in that it can pass action potentials to its neighbours, whereas skeletal muscles need all their own neuromuscular junctions. They work on their own. So that's just a big difference between skeletal and heart muscles. So what would be the advantage in the heart versus the skeletal muscles to an action potential being able to be transmitted?
It'd be a fail-safe mechanism that if if the normal bundle branches are blocked, the impulse can still get through and the heart can still pump.
Yeah, absolutely. So what it does essentially is guarantees a relative synchronicity of contraction. So no matter where the action potential comes from or where the trigger for contraction comes from, it can generate I guess like a functional heartbeat, functional cardiac output. And I'm not going to go into what actually drives the Z discs and actin and myosin filaments to contract, but essentially I sort of consider it like just that they ratchet along each other and they contract, and I don't think it's that relevant clinically, so we're not going to go into it unless anybody has any specific questions about it. Nope. All right, so now looking at the actual electrical generation of action potentials in the heart, and we're going to get pretty deep in this. So where is the action potential, the impulse for contraction triggered in the heart?
Say no.
Great, excellent. Where does it go?
Goes down and to the left to the AV node, so through the atria.
Yep, absolutely. Does it go through a specific pathway, or does it go just cell to cell across the whole atria?
Cell to cell, so it kind of like very evenly kind of disperses across at the same rate.
Good.
It depolarizes across the whole atria.
Excellent. So we get synchronicity in the contraction of the atria.
So where do the Bachmann bundles fit in then?
The bundles are right down the bottom here. So in the ventricles, is that what you mean?
Yeah, they're the bundle branches, but no, what are there were three, as I understood, there were three conduction pathways through the atria, through the right atrium. And I thought they were called Bachmann. No, I've got the name wrong, I'm sure.
I don't know. It's not familiar, and I think I'm sure there is kind of a pathway that guarantees that signal gets through, but specifically in Cunningham's, it talks about how important the diffusion of that impulse is, that it goes across the whole atria. So it starts in the right atrium and then goes kind of in a wave across the left atrium until it hits which point?
So the AV node. So
Good. Excellent. And then what happens?
then it goes, I think is it the Purkinje fibers? So it goes right down the kind of middle septum of the ventricles really quickly.
Yeah.
Because they're sheathed, I believe. So it travels quite quick compared to the rest of the myocardiocytes.
Mm-hmm.
And then when it gets kind of around into the different ventricles, then they depolarize out into the tissues.
Yep, great.
Something along those lines. But it's like really quick, so the ventricles are meant to depolarize together.
Yep.
And rapidly.
Perfect. So
An important thing is though the AV node delays the impulse before it sends it out.
Yeah, why?
To allow filling.
Excellent. Very good. Yep. So, what clinical arrhythmia do we see inadequate ventricular filling?
like atrial fibrillation.
Good, excellent, yeah. And if you look at a ECG of AF, how many P waves are there to QRS complexes roughly? Obviously, there's not a specific ratio. Or not P waves. How many atrial contractions are there to ventricular contractions? How many actually get through?
A lot more atrial contractions. Yeah.
Yes, absolutely, exactly. So with flutter of atria, you'd probably have like 300 to 400 contractions per second, so per minute. Sorry, is that right?
Sure.
Yeah, sorry.
A lot.
Exactly. But our ventricular rate rarely gets above like 240 max, right? Because the AV node is just slowing things down enough that the ventricles can actually fill up so that cardiac output is going to be sufficient to actually deliver blood to the rest of the body. And it's still insufficient. Like obviously there's a decrease in cardiac output in those situations, but the AV node's job is just to slow things down. So it's a safety node. So Josh explained this quite well. The impulse goes across the atria to the AV node and then specifically down the bundle of His out to where it splits into right and left bundle branches. And then they all branch off into Purkinje fibers, which makes sure that that action potential is triggered at multiple locations in the ventricle so that the ventricle can contract all at once. So what stops the impulse from the left atrium jumping down here and triggering an action potential at the top of the right ventricle, for example? Why does it only go through the AV node?
Isn't it like a fibrous band or something?
Yeah.
I don't know. I'm assuming it's just not very good for conduction.
Absolutely. Yeah. So it's just a layer of connective tissue that goes right across, forms a barrier between the atria and the ventricles, so that the only gateway for electrical conduction is through the AV node. What clinical arrhythmia is associated with a hole in that fibrous layer?
Wolf Parkinson White.
Good. Jeff, yeah. What did somebody else say? There's actually two names of this. Oh, I don't think somebody else said something, but it's essentially Wolf Parkinson White is the human name of this condition. We call it SVT, supraventricular tachycardia. There are a couple of different types of supraventricular tachycardia, but this one in particular, essentially the atria can trigger a impulse, and that impulse can either go through the AV node where it will get slowed down, or it will go through this little hole in that fibrous layer and trigger an impulse without any kind of barrier to being triggered. So then the ventricle contracts. But the atria is still only contracting at 100 beats per minute, right? So that shouldn't really be a problem until the signal goes back the other way. So that ventricular contraction is happening while the atria is becoming repolarized and is ready to go again before the SA node is actually firing. So that ventricular impulse wraps around the ventricle, goes back up through that hole and triggers an atrial contraction, which triggers another ventricular contraction, which triggers another atrial contraction, which triggers another ventricular contraction, and you end up with a very accelerated heart rate. Does that make sense?
Mm-hmm.
Let's revisit that. Does it actually make sense?
It does make sense. Is that a congenital thing, Anna? I'm just trying to think, because if there was scarring or infarction, actually that would be more fibrous tissue rather than less. I'm imagining it would have to be congenital.
Absolutely, yeah. So it's we see it in Labradors most commonly.
Okay.
I thought the that's interesting. Supraventricular tachycardia, thought in terms of anything originating in the atrium rather than from the within the ventricles. So yes, I have to revise my thoughts on that.
I think actually, Jeff, you're exactly right. And that's a good indication. I haven't explained it very well. So it is still the atria triggering the contraction, but the ventricle is triggering the atria to trigger the ventricle. So it's the ventricle. So the actual pathway of contraction is still in that. It starts in the atria, goes down, triggers the ventricle, but then instead of starting in the SA node, the atria down here starts the contraction, and instead of being at a nice even pace, it's triggered just as soon as the ventricle passes that electrical signal back through again. Let's go back to that concept once we're talking more about ECGs.
The other question was, I understand in the dog there are 2 left bundle branches. Now, in humans, is there only one?
I don't actually know. This is a veterinary physiology book. I don't know. Sorry, Jeff. That's one for the Google. So I put this picture up mainly just, I guess, to really highlight the difference between, or another difference between the cardiac cells. So one difference is that they can pass the contraction to each other. But the other difference is that the actual duration of their contraction is much longer than a nerve cell. So this is an action potential in a nerve cell. This is an action potential in a skeletal muscle cell. So the cardiac contraction goes for about 4 times as long as, in fact, yes, 4 times as long as a skeletal muscle contraction. Now we're going to go into the reasons for this. One thing I want to highlight is that every cell in the body has a resting potential, usually around -90, where it sits normally. And it just sits in kind of pause mode with all the channels closed, and it's NAK ATPase pump just continuously maintaining the concentration of sodium and potassium inside and outside the cell. And it maintains it so that there's a difference in electricality inside the cell to outside the cell of -90. What ions are important to maintain electrical charge in the body?
Electrolytes.
Yeah, absolutely. Which ones?
Mainly sodium, potassium, calcium, but I guess the extracellular one, well, actually you have to look at both and where they hang out mainly, and then where they're shifted to change that action potential.
Yeah, good. So let's talk about sodium first. Is there more inside or outside the cell?
Outside.
Excellent. Good. At rest. I should clarify, at rest. And the way I sort of picture this and remember this is if I'm looking at a blood test, sodium's high. It's a big number. So I just think high sodium outside the cell. What about potassium? Higher inside or outside the cell?
Higher inside.
Good. Excellent. So we're sitting at -90. We've got a lot more positivity outside the cell than inside the cell. If we just open up the cell, what is going to be the net movement of sodium?
It's going to move into the cell just via concentration gradients.
Exactly, concentration gradient and electrical gradient. So there's a lot of forces to allow sodium to rush into a cell. What happens if that's completely uncontrolled? What follows sodium?
Chloride?
Oh no, good. Yes, it absolutely does.
Water.
Water. Yeah, exactly. So if you have cell damage, like what happens in sepsis, SIRS, ARDS, inflammatory disorders, and you get cell damage, which disables that sodium potassium ATPase pump, and you get sodium influx into cells, you get water following and the cell explodes, it dies. So sodium movement is a really powerful driver of change inside cells, but it has to be really tightly controlled because it's potentially life-threatening to the cell. So maintaining that resting membrane potential is via the NAK ATPase pump actively kicking sodium out of the cell. So using ATP energy to kick sodium out of the cell and putting potassium back in the cell. Because sodium finds ways in because it's such a strong pull into the cell. And that pump is constantly going at rest. So that resting potential minus 90. And then every cell has a threshold potential. So if enough sodium gets into that cell through the slow leak, then it will actually cause opening of voltage gated sodium channels, and it will allow a controlled influx of sodium. So that's what the threshold potential is. So the threshold potential is the membrane potential, the electrical change from negative to positive, which will then trigger an opening of an ion channel to then rapidly change the positivity inside the cell. And I said sodium before, there are other cells that use other ions, but for the sake of the cardiac cells, that threshold, when enough sodium gets in, that threshold potential is reached, voltage gated, so voltage being the electricality, voltage gated sodium channels open, and sodium rushes in to the cardiac cell. And that's phase 0 of the action potential. Phase 1 is where the cell starts to go, oh my God, too much sodium, and starts to decrease the amount of sodium in there via those NAK ATPase. So the positive ion goes out of the cell a little bit and we get the beginning of repolarization. Now the cardiac cell doesn't want to repolarize. It wants to stay contracted to get sustained contraction to facilitate cardiac output. So how could it facilitate that? Now that sodium is kind of cut off, what other ions can it lean on to maintain that contraction?
Well, we use calcium channel blockers, so I'm going to say calcium is one of those.
Good, exactly. So phase 1 is sodium channels closing and a decrease in sodium. Phase 2, calcium channels opening, allowing calcium to come in. That's a really important difference between the myocardial cells and the skeletal muscle cells. Skeletal muscle cells don't have membrane calcium channels. So calcium is involved in their contraction, but they don't get that calcium from extracellularly. The calcium channels open in phase 2, and there's one other ion channel that closes in phase 2.
Potassium?
Good, excellent. So that maintains all of the positive ions inside the cell. So permeability is essentially just shut down for both potassium and sodium. And calcium, it's increased. So we've got calcium going down its concentration gradient into the cell. Then what do you think happens in phase 3? We've got the positivity inside the cell going down, so we must have a movement of positive ions out of the cell.
Is the sodium pumped out of the cell?
Not yet, actually.
Not yet.
Not yet.
The only other positive one left is calcium then, surely.
One more.
Magnesium?
Actually, potassium. So
more potassium goes in, so the potassium can't get out, and then more is invited in or allowed in or pumped in.
Going back to potassium, higher inside the cell or outside the cell at rest?
Inside the cell.
Absolutely. So we've got lots in there and it's staying in there. We've got the potassium channels closed in this phase. And then all of a sudden, the potassium channels open and potassium goes down its concentration gradient outside the cell.
Okay.
So then we're back to our baseline resting potential here. But where's our sodium?
Still in the cell.
Still in the cell. Where's our potassium?
Still,
It's out of the cell.
yeah, out of the cell. Swap.
Yeah. So now what happens?
The pumps swap them back, don't they?
Good. Exactly. Yep. So obviously, if you've got a cell full of sodium and you open your sodium channels, the sodium is not going to flood from extracellularly to intracellularly. There's no concentration gradient there. So until you've swapped the potassium sodium back to the point that the concentration gradients are corrected again, you can't trigger an action potential. Does that make sense? Yeah?
Mhm.
I love this stuff. Sorry if everybody else is bored.
Not at all.
Okay, so looking at that again with the different ions. So I don't know why they started with potassium, because it starts with sodium and I like to do things in a timeline. So we're going to start looking at the sodium here. So the cell lets a little bit of sodium in, reaches that threshold potential, opens its sodium ions, and you see the permeability at this point of sodium goes through the roof and then it shuts down again. So that first little spike is all sodium. If we now look at what's happening with potassium, it's got reasonable permeability, then that permeability shuts down to maintain that positivity inside the cell. And then all of a sudden it actually increases above baseline to allow all of that potassium to flood out down its electrical gradient and concentration gradient. And then it goes back to baseline. And then looking at calcium, the calcium channels aren't as fast as the sodium ones. So the electrical change that we see as a result of calcium is more of a curve rather than a spike, excuse me. And in the cell, we've got very low permeability initially. When we get to that phase 2, permeability increases and it flows down its concentration gradient into the cell. And then those calcium channels close again and permeability cuts off again. Is that all right with everybody?
Yep.
Okay. So this is where the heart gets really cool. So obviously, if all the cells in the heart were deciding to fire just autonomously, you'd never get asynchronous and organized ventricular contraction and cardiac output. So pacemaker cells are actually quite different from our ventricular cells, which this refers to. So again, we've got a resting potential and a threshold potential in the pacemaker cells. So these are the cells of the sinoatrial node. And you'll see here that the resting potential is not really a resting potential. It's just a constant climb. So pacemaker cells are consistently permeable at rest to sodium. So that means that as the sodium floods into the cell, it's going to reach that threshold potential. So that's what dictates how often the heart is going to fire. That sort of controlled allowing sodium to flood into the cell. So instead of it being an influx of sodium that causes the action potential, so we don't get a big spike in the sinoatrial node cells, it's actually an influx of both calcium and potassium that facilitate that contraction. So sodium is much more important in triggering an action potential, but it's much less important in the actual generation of electrical movement in the pacemaker cell. So this is what I really like the name of the sodium channels in the pacemaker cells. They're called funny sodium channels.
Did you say funny?
Funny.
Really?
Funny.
F-double-N-Y, yeah.
Okay. I thought they were called leaky. I always knew them as leaky cells.
Oh, really?
Yes,
Maybe I'm
because
wrong.
they constantly kind of leaks or sodium into the, like, I imagine it like dripping into the cell, and then
That's what I imagine.
we trigger a potential.
Yeah, I wonder if the leaky ones are the ones that trigger the action potential in normal cells, whereas these
Okay.
ones have a very consistent influx of sodium, so they let more sodium in, but in quite a controlled way.
Okay.
So these funny sodium channels are managed. I know it's good, isn't it?
Yes.
So the rate of sodium flooding into the cell is what actually dictates the heart rate. Because if you let sodium in faster, you're going to trigger an action potential more frequently than if you let it in very slowly. So what chemicals might act on those sinoatrial node cells or those funny sodium channels to influence heart rate?
Catecholamines,
Yeah, which one?
adrenaline, noradrenaline.
Good, excellent. So there's two different ways that the sympathetic nervous system can impact heart rate. One is by like adrenal glands just flooding adrenaline and noradrenaline into the system and activating the beta receptors. The other is actually local. So there's sympathetic nervous, like actual local stimulation of noradrenaline as a neurotransmitter that also works at the sinoatrial node cells. So what's that going to do to heart rate?
Increase it.
Increase it. Excellent. So do you think it increases funny sodium channels being open or decreases?
Increases.
Increases. Good. Exactly. So I just wanted to make sure you had the concept of that you increase in heart rate is associated with an increase in sodium influx. So more channels open, more sodium influx. Okay. What neurotransmitter will decrease the heart rate? Or what system decreases the heart rate?
Parasympathetic,
Good.
acetylcholine.
Good, Jeff. Excellent. So acetylcholine decreases funny sodium channels and decreases sodium influx, which means it takes longer to trigger an action potential. Cool?
Mhm.
Yeah.
So when we're about to give, say, a lecture or do some public speaking, and our heart rate's going like a rate of knots because our sympathetic overdrive, and we have a beta blocker, is that influencing these channels, or is this influencing, God, I'm getting myself into trouble here where I'm always thinking, forgetting beta and alphas and blah, blah, blah. But is that playing a role here, or is that completely different?
Absolutely. So beta blockers will decrease heart rate and they'll decrease force of contraction by the interaction with the beta cells at different areas of the heart. So the area where it impacts heart rate is the cells of the sinoatrial node.
Okay.
Yeah, and then the rest of the heart muscles have beta receptors as well that impact the force of contraction and calcium cycling and things like that.
Okay. Thank you.
But yes, quite beneficial for public speaking. Yeah. I'm just going to keep an eye on the time because I don't want to keep you too long. We want to get to ECGs. So then, again, I'm just so visual that I just like this picture of where the conduction goes and how it goes. So, and then we're going to move on to how so we're talking about the electrical signals in the heart, but then how long after the electrical signals the contraction happens and stuff. So again, we've got trigger of an action potential in the atria. We've got it diffusing throughout the atria, hitting the AV node, and then going down through the bundles, the common bundle of His and then the bundle branches, and up into the right and left ventricle and causing a synchronous contraction of those. This image is there's a lot of information in it, but the main thing I want to point out is that the AV node itself has pacemaker potential in it. So if the sinoatrial node dips out and we're not getting any atrial contraction, what happens?
Yeah, the AV node will kick in at a rate of about 60 a second.
Good. Excellent. So what we're seeing in this image is the sinoatrial node depolarizing, triggering the AV node to depolarize a couple of milliseconds after the fact, and a normal kind of pathway of conduction. If you get no sinoatrial stimulation of the AV node, there'll be a big delay, but eventually those funny little sodium channels will let enough sodium in. So there's less of them in the AV node. So it takes longer to trigger a depolarization, but eventually you'll get a depolarization. And the ventricular rate is consistently under 60. If you've got a rate of 70, it's not originating from the ventricle. Okay, so I just want to make this very real for everybody talking about ECGs. Does everybody remember physics? And
Try not to.
yeah, exactly. This is just so physics, but vectors and measurement of movement. So I think the ultrasound physics is the reason why this really kind of makes sense to me. So if I want to measure the velocity of something, I want to line up. Okay, let's use a speed camera as an example. If you've got a policeman pointing the speed camera perpendicular across the road, he's not going to be able to accurately measure your speed, is he? How would he most accurately, he's obviously a man because he's a policeman, sorry. Where would he have to position himself to most accurately measure velocity? Diagonally or
parallel.
Yeah, absolutely. So if he's standing in the middle of the road, pointing the gun right at you as you're driving towards him, that's going to be the most accurate measurement of speed. So anytime you're measuring anything that's slightly off the line, there will be a degree of under measurement. So if we think about the way that the heart sits in the chest and the ECG leads we're using to measure electrical velocity or flow through the heart, we need to have a really good kind of picture of where the flow is going and how that relates to the lead that we're looking at. So I just want to point out the heart sitting in the chest, the apex tips slightly towards the left in most normal animals. This is actually a dog with heart failure, so it's not a great example, sorry. But apex obviously sits slightly towards the left. So our lead 2, which is coursing from usually the right elbow to the left leg, is really nicely lined up to catch flow through the ventricle. So as it goes down through, down through the bundle into the bundle branches. So we get a really nice line up of that initial conduction through the ventricle. Whereas when we're looking at an impulse originating on the right side of the heart in the atria, in the sinoatrial node, and traveling across to the left side of the heart, it's going to be better picked up in lead 1 because it's better lined up for the flow of electricity. Does that make sense? Let's look at it. The reason I just wanted to put the arrows in, but if you think lead 1 goes right limb to left forelimb, so it goes straight across like this. Lead 2, right forelimb to left hind limb, so along the axis of that septum. And lead 3 goes left forelimb down to left hind limb. So the initial impulse that we see from the sinoatrial node causes electrical activity to course through the heart towards the left hind limb, essentially. So along that axis, yeah? So which lead would you expect the P wave, which it represents that atrial electrical activity, to be biggest in?
1.
1 going from right to left. So then it's probably going to be about equivalent because it's moving across slightly kind of between the two leads. So 1 and 2 are probably going to be the biggest.
Yeah. Okay.
It's going to be barely visible in 3, which is almost going kind of opposite or potentially even inverted. So then we get the initial conduction through that bundle of His. And we've actually got, through the AV node and the start of the electrical conduction through the ventricle. And as the conduction heads down the septum towards the left hind limb, we see a big positive deflection. And as it goes back up the ventricular wall, up here, it goes negative again because it's going away from the left hind limb. So it goes towards and then away. Does that make sense?
Doesn't it go negative and then positive then? Isn't it?
It goes, so the positivity, so that sort of influx of cells goes down the septum initially, and then out through the bulk of the ventricular wall. So it should, do you mean like the Q wave?
Yeah.
Yeah. So I don't really understand that, I have to say.
Okay.
I didn't find a good explanation. I actually read about it specifically in Cunningham's because I couldn't really explain it.
I watched this video.
Sorry?
I was going to say, I watched this video. I think there is like a very small little branch that comes off that bundle of His that depolarizes the septum at some point.
Oh.
And that might be it, but that was a human video I watched like a couple of months ago now. So yeah. Max might know.
Yeah, that's what I have heard too. So it's the depolarization from the left side of the septum to the right side that create a negative.
From the left side to the right side creates a negative. Okay. Right. And then when it actually causes the contraction of the ventricular muscle, we get that big positive. So when the bulk of the contraction is in the bottom, and then when that contraction spreads to the top of the ventricle, we see that deflection.
Yeah.
Okay.
But I think it's like all still very synchronous because the septum is quite a slow depolarization, and by the time it's gone through the bundle branches and depolarizing from the ventricles, it's all kind of happening at the same time still.
Good.
I think.
Yeah. Well, yeah, I mean, that would make sense.
I mean, the Q wave's more visible in right heart enlargement. No, I'm not sure why.
Let's think about that. So if what Max has said, so Max said that there's movement of the electricity across the septum, so from left to right. So if you've got right-sided cardiomegaly, then you're going to get an increase in cells on the right side and an increase in impulse on the right side. So if we've got a vector that we're trying to measure going across the heart like that, we're going to pick it up as a positive in the lead 2 and as a negative in the lead 1. Is that right?
I guess that makes sense, I suppose.
Oh, I'm confusing myself. I'm probably confusing all of you too. Sorry. So sorry, I'll just go straight onto repolarization because that's all a little bit confusing, but essentially that's the way I think of it, is the ventricular depolarization, and then repolarization is usually a positive wave, but it can be quite variable in dogs and cats. And that reflects obviously the switching of sodium and potassium in the cells, so that repolarization, essentially. Sorry, I think I'm going to move on. I'm just confusing myself. So
You need your policeman back here again.
I know, exactly. I have this, like, I feel like I've got this concept so down, and then when I try and make it into words, I'm like, oh, I don't know.
It's the physics of vectors, or the parallelogram of forces.
Yes.
And if I ever find it, I'll send you the ECG dance that was done at CSU.
Oh, I love that. I have seen that. It's so funny. So the reason I was trying to get this concept across to you guys is because it really helps me to comprehend what I'm looking at when I'm looking at the 3 different leads and why we need to use the 3 different leads. Now, for the moment, I actually really want to ignore the AV leads because we're not cardiologists, and realistically what we're looking at and the arrhythmias that we're interested in will all be diagnosable on the 1, 2, and 3. So the concept I wanted to get across to you is we can really get information about the axis of the heart, where the bulk of the heart muscle is, on the height or amplitude of the electrical signal going through it. So, for example, looking just at the QRS, so just at the main sort of ventricular contraction, if I've got right-sided cardiomegaly, instead of my impulse being straight down the middle of the heart, so straight from right to left, it's going to be a little bit more that way. Oopsies. Sorry. It's going to be a little bit more that way, which if that's the case, which lead, either 2 measuring that way or 3 measuring that way, is going to have a taller QRS complex? If you've got
Probably 3.
Yeah, I agree. Because the axis of the heart has changed. The direction or the bulk of electrical activity is going to be more towards that axis of the 3rd lead. So if you're looking at leads 1, 2, 3, and you see the QRS is bigger in the 3rd lead, that's a really significant finding. What about, let me just check my notes here. So what about if we've got a P wave? So should P waves always look the same?
In a healthy animal, yes.
Yeah, I agree, because their pathway of conduction is really consistent. They should always look the same. Same as QRSs, it should be really consistent. Do they always look the same?
No.
No, even in healthy animals?
Probably in healthy animals, they're nearly always the same.
It's that with increased parasympathetic tone, so increased vagal tone, increased ACH, dropping that reactivity of the sinoatrial node cells, sometimes we get what we call a wandering pacemaker, which means that the actual stimulation for the heart, for the atrial contraction, actually doesn't come from the SA node. One of the other cells has got excited before the SA node did, when we've got very high vagal tone. So for example, under very heavy sedation or anesthetic, sometimes we see wandering pacemaker, and you can see the P wave looks different because the contraction or the electrical pathway is variable depending on where that stimulus arose from. What about, say we've got sick sinus syndrome and we've got no impulse coming from the sinoatrial node. What is our QRS complex going to look like?
If it's fired from the AV node, it should look normal.
Good, excellent. So that's exactly the point I wanted to make, is that if the AV node is setting the rate, the only abnormality on your ECG is going to be the absence of P waves and a very low heart rate, obviously. What about if I've got an infarct in my left ventricle, which is stopping conduction through the main body of the heart muscle on the left, which lead is my QRS complex going to be higher in?
2.
I actually think, so this is a bit of a trick question because the pathology is on the left, so it makes you think the electrical activity is going to be on the left. What impact does an infarct or fibrosis have on conduction or electrical conduction?
It's going to reduce it.
Yeah, so relatively, we're going to have more conduction through the right side,
Oh, okay.
which should be taller in which lead?
3.
3, exactly. Beautiful. Okay, what about if I'm a boxer with fibrofatty infiltrates in the right side of my heart and I've got more conduction through the left side as a result? Which lead will it be taller?
2.
2, excellent. And it'll be a lot taller in 2. So it's always tallest in 2, or it should be always tallest in 2, but it will be the difference will be significant. What about if we've got HCM? What will what difference will that make to our electrical activity that we're measuring via ECG?
It's going to be wider. The QRS is going to be wider because it's more muscle there, muscle cells to go through, so it takes longer, I guess.
Yep. And it's also probably going to be taller. So increased magnitude of signal because there's just increased electrical activity. Again, this is so subtle, but these are the sorts of things that they talk about in the book, doing the measurements of the milliseconds and things like that. What about VPCs? What are VPCs?
The electrical conductivity is coming from the ventricles rather than the SA node and the AV node. So they're dysregulated, they're not synchronous, wide and bizarre because they don't follow that beautiful synchronous pattern that they should.
Absolutely. Now I'm just going to think about this to make sure I get it right. If you had a VPC originating in either the AV node or the bundle, Jeff's already answered what it would look like. Does somebody want to just tell me again? Somebody else, Jeff? Sorry. So if you've got oh my God. Sorry. If you've got a signal being generated or action potential being generated in the AV node or the bundle, what will the QRS complex look like?
It'll be same. Yes.
Exactly right. What about if you've got a VPC arising on the left-hand side of the heart? Just in the myocardium.
It should be more obvious in lead 3.
Will it go down first or up first?
I think.
Negative deflection first.
Beg your pardon, Max?
I think negative deflection.
If it arises on the left,
Yep.
it goes down first.
Hmm.
Yeah. Left is lower. So if you think about the position of the heart, left side of the heart is here. You've got an impulse generated there. It's actually going to go up. Ooh. Yeah. It's actually going to go up and away. So it's actually going to be measured as negative. So it's going to go towards the negative on this lead 2 first, and then it's going to come back around and go positive. So it's going to go down negative first, it's going to go up and then come back. So left is lower. That's how I remember that for VPCs. What about a right VPC? What's that going to look like?
The opposite.
Opposite. Yeah.
Opposite, exactly. Yeah, exactly. So they're the VPCs most commonly see in boxers with boxer cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, are often right-sided to start with, but then we get a fibrofatty infiltrate on the left side as well, and their morphology gets a little bit more variable. What about a block of the bundle branch? And I'm going to go back to the image of the bundle branches here. So what about if I've got a left bundle branch block, and that means the conduction has only gone through the right bundle branch? What is my ECG going to look like? My QRS complex?
It's
Like a positive deflection.
Positive deflection first. Yeah, absolutely. Good. And it's a little bit tricky because I sort of left VPCs go down first, left bundle branch block. It's like when I caught you, Alison, with the illness on the left, actually decreases conduction on the left. So left bundle branch block will go up first. Left is lower for VPCs, left is higher for bundle branch block. What about, and this will be my last thing and then we'll sign off. What about, what's the most common arrhythmia we see in healthy animals under anesthetic?
Like a sinus arrhythmias.
Sinus arrhythmia. I actually meant ventricular arrhythmia. Sorry, that's naughty. You were exactly right. So I'm just going to tell you, it's a right bundle branch block. It's really, really common with increased vagal tone. And how will that look on an ECG?
The left ventricular depolarization.
It will
So
look
negative.
exactly, yeah, exactly. Yeah. So they're the kind of common sort of ventricular or QRS abnormalities we see on ECG. We're going to talk more about the neurohormonal mechanisms of congestive heart failure next week. So first chapter in Edinger, we're only going to cover that chapter because there's so much to talk about in there. So much less pre-reading next fortnight, sorry, not next week. And then within Edinger, we're going to cover ECGs again, but I just really wanted to get deep down into the electrical side of things. All right.
Cool.
You can all go and enjoy your day.
Thank you so much.
Thanks, Anna. That was awesome.
See you guys.
Yeah.